Okay, with that, I'm going to turn things over to Gwen and Devki. Oh, I think you're on mute.
Hello, everyone, and thank you so much for joining us today. I'm Gwen Turner, and Patrick, thanks so much for that introduction. I'm joined by my colleagues, John and Devki, and today we're going to talk about National Minority Mental Health Month and how health disparities are playing out in communities of color, and how we can use technology to better assist communities of color as we look at mental health. And we're really happy to be here today to talk with you about this, and we welcome any questions that you have along the way. So be sure to type those into the Q&A box, and then if you have other thoughts that come to mind, please use the chat box too. We'll be monitoring that as we go along. Next slide. So a little bit about our session today. Today, we're going to talk to you a little bit about who we are and what we do at Myriad Genetics, what we're up to in terms of Minority Mental Health Awareness Month. And then also, we're going to talk about some of the impacts and health disparities that really are impacting communities right now. We know that COVID-19 has amplified mental health. It has also allowed us an opportunity to really talk about these issues. And so today we're going to talk about some of the things that we're working on and some potential solutions, but things that we can do collectively as partners in this space. Next slide. Then, of course, we'll be taking Q&A, but then along the way, I ask you to put any questions that you may have. Our organization, Myriad Genetics, many of you are already familiar with Myriad Genetics, but for those of you who are not, we were founded in 1991. We're located in Salt Lake City, Utah, although our employee base is very dispersed. We have people who are all over the country, and we specialize in a number of specialty areas. We have over 2,400 employees. And again, we span the national scope. We even have colleagues who work international as well. We've administered hundreds of thousands of genetic tests. So we are a leader in this space in performing genetic testing. And we're also well respected by physicians as well. So we've been doing a lot of work to partner with physicians on our tests, but then ways that we can offer assistance to communities that may be underserved. We're also published in over 1,000 scientific publications, and we partnered with a number of institutions, education as well as medical institutions in order to better healthcare. We specialize in 3 main areas. So these are our core areas. The first is under women's health. We have a women's health division, mental health and oncology, and all 3 of those make up Myriad Genetics. And our sole purpose is to create these tests, genetic tests, that will help us determine the risk of developing disease. We also assess the risk of disease progression. And then also we provide an opportunity to guide our treatment decisions across medical specialties as well. Next slide. As it relates to July, which is Minority Mental Health Awareness Month, our organization is doing a number of things in order to bring mental health to light, but also to really talk about the trauma associated with some of the recent things that have happened, like the shootings that we've seen, some of the shootings in Uvalde, as well as the shooting that occurred in the grocery store in northern New York. Many of our colleagues internal are struggling with mental health as it relates to the trauma associated with those things. And so internally, we're doing a lot with our employees, and we've partnered with a company called Spring Health to offer sessions to help our employees deal with those things. We also extend that benefit to the families of our employees, which I think is really phenomenal to be able to do something like that. We are also doing a series of sessions around minority mental health awareness for physicians as well, not only for them to get to know our product Genesite, but also for them to understand some ways that they can really partner with communities of color to assist as it relates to mental health. We know that, like I said earlier, that COVID-19 has really magnified some of these issues for us. But what it has done is also been able to give us an opportunity to really bring mental health to light and to have people address mental health with themselves and with their family members. And so we think that we have a unique opportunity to really be a player in this space in helping communities of color. Next slide. Some of the things that we've done from a health equity perspective, a part of our diversity, equity, and inclusion strategy is to focus on our internal workforce through recruitment and retention and creating a place of belonging. But the other is really around our health equity strategies. How are we reaching back and helping these communities of color? And so we've done some really cool things in the last 2 years around health equity. The first is our partnership with Xavier University. Xavier is a historically Black college located in Louisiana, and they are establishing the second ever genetic counseling program at the university. This program is an opportunity for us to really build the bench of genetic counselors. Today, 95% of the people who are genetic counselors are women, and they identify as white women. And what we want to do is to ensure that we are bringing more diversity into the pipeline, because what we found is that many people who want care really want to see people who look like them in this space so that they can relate and understand their journey. And so we've decided to partner with Xavier University on this program. The program will be up and going on next year. And we're really excited because we have students who are already ready to enroll in this particular program. We think that it's going to be an exciting opportunity for us to be able to recruit talent from the program, but also to be able to do more in the industry as it relates to inclusion and equity and health literacy. The second thing that we were able to do in the fall of last year was we launched Risk Score for All Ancestry. And this is a game changer for us. This is an awesome opportunity for our company to really demonstrate the research and the work that goes into understanding what a woman's risk is for breast cancer. So this test traditionally was for European women, women who are of European descent or background. And now we've been able to do the research and the testing in order to be able to provide this test for women of all ancestries. So we launched Risk Score for All Ancestry so that any woman who wants to know her risk can get that can get that test and be able to have that. So that's Risk Score for All Ancestries, and that was launched in the fall. And then just recently, we had a really big win for our organization. We launched our inaugural ESG report. And if you want to know more about our organization, I would ask you to simply, you will have this presentation, so you'll have the link to it, but you can also Google Marriott ESG report, and you will find some very interesting information there about the work that we're doing in terms of environmental, social, and governance. And so we have a lot there in terms of what we're doing from a workforce perspective, as well as the efforts that we have to partner with organizations that are advocating for health equity. So I'll pause there and I'll turn it over to my colleague, Devki, who will go more into health equity as it relates to technology.
Thanks so much, Gwen. I really appreciate it. Thanks for that wonderful overview. And so I think, as you can see, Myriad is really excited about this opportunity to really participate within the community around addressing health equity. And we all understand that health equity is really multifaceted and requires a variety of stakeholders coming together to have these important discussions. So we're excited to be here today and look forward to the opportunity, hopefully following this webinar, to be able to really speak with you about areas of focus for your organizations, and are there some opportunities for us to collaborate. As we've been having conversations, one area that I think we've heard sort of universally as an area of focus with a lot of health plans is in the area of mental health. And so I'd like to transition now to start talking just a little bit about mental health and health equity. I'm having some difficulties advancing, so all right, here we go. So I am sure to this audience, this really is not a new topic of conversation. We know that Medicaid is the single largest payer in the US for mental health services. And that really stems from just the prevalence of mental health conditions within Medicaid enrollees. I'm sure it's not a surprise to you to see, 1 in 5 adults with mental illness have Medicaid as their coverage, and up to about 1 in 3 individuals who are low-income enrollees have a diagnosis of depression. I think what makes this group so unique and why we were really excited to talk about mental health is the fact that you really have a very diverse enrollee population. So this MACPAC data indicates that about 61% of beneficiaries of Medicaid report a non-white race or ethnicity as their primary background. And so your organizations really have been in the forefront of trying to really address minority mental health and find ways to help improve outcomes in this population. And as Gwen mentioned, one of the big challenges is the data that I shared with you on the previous slide in terms of prevalence was really pre-pandemic data. And so when we look at the impact of the COVID-19 pandemic, it's really been magnified when we look at the number of individuals experiencing depressive symptoms. And so this may not be news to you, but just to sort of ensure we're all on the same page, pre-pandemic, there were about 7% at a national level of individuals that had depressive symptoms. When we fast forward and look at the course of the pandemic, you can see that there really was a dramatic rise in individuals experiencing depressive symptoms. Early on in the pandemic, up to 31% of individuals. But even as the pandemic has sort of kept going, we can see just as of last month, still 22% of individuals have depressive symptoms. Now, when we think about this, really the pandemic and data has shown that it's had an outsized impact on individuals who are of low income and minority backgrounds. And so when we look at this data around the prevalence of these symptoms in Hispanic individuals who report Hispanic or Latino background or non-Hispanic Black background, you can see that those rates have gone up, but they have been sustainedly elevated over sort of the national levels. And this is a really, I think, important issue to be aware of, because when we think about mental health, and access to mental health and utilization of mental health services, we all are aware of the data that really shows that individuals of non-white background are less likely to actually access mental health services. And so this is some data that comes out of the US Department of Health and Human Services Office of Minority Health. And as you can see here, sort of across the board in adults who have mental health conditions, individuals of Hispanic and non-Hispanic Black backgrounds are much less likely to access mental health services. And even if they do access those mental health services, they're less likely to be getting treatment. And that's a real challenge. And actually, there was a recently published report that came out of the Health of America report by the Blue Cross Blue Shield Association. I think it was published in May of this year, which really, I think, highlight these same points. And what they really found as well was that the rates of treatment for major depression were lowest in communities of Hispanic background and also in Black communities as compared to white communities. And that even when individuals did come forward to get treatment, they were less likely to have prescription drug treatment or counseling. And what this really means when we think about the prevalence of depression in combination with this data is that there are more individuals in minority populations that have untreated mental health conditions. And this is really a significant issue, as we know that there's clear evidence which shows that early intervention in depression treatment is correlated strongly with improved outcomes. And so it's really important to try to identify and get those people into care so that way we can help them resolve their depression and get them back to really a good state of functioning. Additionally, with depression, whether it's untreated or not treated successfully, is that it can really have negative impacts, both on continued mental health, but also on physical health outcomes. And so, there are a number of reasons why we see this disparities. And the American Psychiatric Association has really identified some key barriers to care that are unique to minority populations. The first one that you can see on the left here is mental illness stigma. In that Health of America report, the Blues Plans has reported that 54% of Black respondents and 47% of Hispanic respondents reported that individuals with mental health conditions in their communities are looked down upon. And that was compared to only 38% of white respondents. So clearly a really significant issue when the people that you would normally turn to talk about challenges that you're facing are going to potentially look down upon you. The other area that they really focus in on is, I think what data has shown is that minority populations, when they're looking to seek out mental health care, they're looking to see clinicians that they feel like they can relate to, so either by background or experience or language. And so the lack of diversity amongst clinicians and language barriers can be another reason why individuals from minority populations may not seek out the care they need. And then I think there's just this overarching distrust in healthcare, and that can stem from either this, not seeing clinicians that look or feel like they can be you can relate to, but also personal or even community experiences in healthcare. And so, these are all really challenging areas, but it has been really wonderful to see a lot of the work really that the Medicaid health plans have done in this area, but also communities at large. And so before we jump into sort of the next section of our discussion, I'd love to turn things over to Patrick for a quick poll. We'd love to get a sense of what some of your organization's engagement is around diversity, equity, and inclusion, and then also sort of what you see as within depression, some of the challenges in treatment. So I am turning it over to Patrick.
Wonderful. And we have folks responding. Still have time. And we'll share the results for everybody. Okay, give it a few more seconds, then I'll close the poll. Okay, last chance. Here you go.
Awesome. Thank you, Patrick. This is great to see. Everybody feels like their institutions are at least sort of working on it or definitely on it, which is fantastic to see. And so I think as we continue this conversation, we're looking forward to hopefully hearing a little bit about what some of your organizations are doing, or even following this presentation, having an opportunity to talk a little bit about what some of those initiatives are. Because as you've seen, we definitely are focused in this area and looking forward to having conversations. So on to the next question.
Do we want to do the second poll now?
Yeah, if we could, that would be great.
You bet. Here we go. Awesome. We're getting great results. Thanks, guys. Appreciate your participation. Give it a few more moments here for folks who are making up their mind. Okay, last chance. I'm going to go ahead and end the poll. Hope you're muted.
Sorry, I'm on mute. I should know this by now. So it looks like the top two choices really are around availability of mental health professionals, which we all know is a really big challenge, as well as addressing the stigma associated with mental health conditions. But not too far behind, also more funding for programs and initiatives, which I think we're always looking for, as well as leveraging technology. So thank you so much for sharing this information with us. And I think these are all areas that we're really focused on, is how can we sort of partner with organizations to help address some of the issues. And I hope as we go through the rest of our conversation today, we'll sort of be able to touch on ways in which we're trying to help in these areas, or ways that we'd love to be able to partner with you and your organization. So with that, thank you for your participation, and we will jump in. So one of those options was around sort of leveraging technology to help improve access to care, which hopefully also then is able to address some of those areas around stigma, but also availability of mental health clinicians. And I think one of the things that we have really seen is a push towards looking at ways that technology can help enable health equity. And so, I think one of the pieces that we have definitely seen in action, especially sort of, I guess, accelerated in the pandemic, is looking at things like wearables, apps, telehealth solutions to help address some of the challenges that we have seen in access to mental health care, but also in it to be able to sort of normalize and sort of address some of the concerns around the stigma that we've seen. I think interestingly, the other component is not only are these tools being developed and now being made more available, but there's actually still a lot of research that's going on too. It's great to have the tools. And so on the bottom of the screen here, how do we really help facilitate and eliminate barriers to the utilization of those tools, especially in minority populations? So there's a lot of work that's going on there. It's not enough to just have the tool, but how do we make sure that it's widely accessible and people are actually utilizing it? And then interestingly, there's a 5-year study that's being funded by the National Library of Medicine called the Unbiased Study, which is also looking at ways in which technology can help uncover hidden biases that might be going on in the provision of healthcare, right? And that's really important when you think about distrust or people feeling like they can't relate to their clinicians, is these hidden biases can sometimes play out. And so how can we be made more aware of those and therefore address them, so that way we can ensure more equitable care for all of our patients? And so when we think specifically in the area of mental health, there are a number of challenges to the successful treatment of depression, which we've outlined here on this slide. And I'm sure most of these are not new concepts as you look at this. But we've also seen technology really being implemented to help address some of these. So things like access to telehealth services, being able to help with the access to mental health professionals, and somewhat also addressing that fragmented care system. So now you don't have to have patients going from one clinic location to another when, social determinants of health, they may not have transportation, they may not be able to take time off of work. So some of those sorts of tools, as well as tools really in the area of trying to address social determinants of health to help connect people to the resources that we need. When you're looking at this circle, obviously there's a variety of different reasons why treatment of depression is so challenging. And one that might not jump to mind is how the variation in our genetics can actually impact the efficacy of treatment. And so that's here listed as genetic variability. And this is really the field of pharmacogenetics, which is a fancy way really of saying how can our genes and our genetics actually help inform medication selection and dosing. And so I'm going to, before we jump into sort of the genetic technology in this area, I'd like to take a moment to just speak a little bit to how do genes really impact outcomes with medications. And so you may have seen this play out a little bit, either personally or hearing from others, where someone's considering giving Benadryl to their child before a long flight or a long car ride with the idea that that will help calm them down. But when they in fact give the medication, give Benadryl to their child, they actually end up hyperactive and completely on the opposite end of the spectrum. And so that's not something you can tell how that child is going to react to the medication just by looking at them. And that's the same as we think about just really medications in general. And what we know about our genetics is that genetics can actually impact how we each metabolize medications that we take. And so if you look at this sort of graphic that we have here and start on the left, we know that for some individuals, for a particular medication, their genetics may make them at what we call an ultra rapid metabolizer. So this is someone that metabolizes medications much more quickly than we would anticipate. And as a result, they have too little drug in their symptom to help treat the condition that they are taking the medication for. So normal doses, you're not going to see the efficacy that you would typically see. The next is a normal metabolizer. So a person who, from a genetic perspective, metabolizes medications in a manner that we would expect to see. And so probably will find efficacy at normal doses. And then on the other end of the spectrum, we have individuals who metabolize medications too slowly. So they're intermediate or poor metabolizers. And for these individuals, when you're metabolizing medications too slowly, you actually end up with a buildup of the drug within your system. And this can really lead to side effects, even at normal doses. And this is particularly challenging when we think about treatment of depression, because many of the medications that are options for the treatment of depression do have side effects. And while they might be mild in nature, they really negatively impact quality of life, whether that's weight gain, whether it's sleep disturbance, sexual function, all of those things. And those can really negatively impact adherence to medication, which then is, one of the challenges we saw on the previous slide, is to get someone to sort of a successful treatment end, we want them to adhere to their medications. And so this is really where this concept of genetic technology and pharmacogenetics can really be a helpful tool. Is without sort of doing the genetics, we can't tell just by looking at someone which category they fit into for any particular medication. So someone might be an ultra rapid metabolizer of one medication, but they might be a poor metabolizer of another. And so that's where Myriad really brought our expertise in the area of genetic technology, is to develop the Genesite test. So Genesite is a once in a lifetime laboratory test that's actually covered by Medicare, which utilizes genetic technology to actually evaluate multiple genes that are known to impact the metabolism of psychotropic medications, and then utilize that information to look at what that impact might be for a particular patient for over 60 different medications that treat mental health conditions. And Myriad's able to take this information and actually put it into and distill it down into an easy to use report. And so I've highlighted here sort of an example of what a report looks like. And you can see that there's sort of 3 bins, green, yellow, and red. And the idea behind this is that the medications that fall into this green category are those where they can be used as directed. There are no predicted gene-drug interactions that we would imagine that are going to impact the metabolism of that drug. So those drugs can really be used as directed. The second category is yellow in the middle, where you've got a moderate gene-drug interaction. And in those cases, an individual might be, say, an intermediate metabolizer, and so maybe a lower dose is something that you might want to consider if that's going to be the drug you want to utilize for that patient. And then on the right side is the red group of medications, which are those that have significant gene drug interactions. So these are ones where based on the patient's genetics and metabolism, they're likely to have significant gene drug interactions, which may lead to increased side effects or other challenges a patient might have. Now, the goal of the Genesite test is not to supplant medical decision-making. We know there are a variety of issues, clinical, but also personal, that a clinician factors into when choosing a medication. But the goal of this report is to really help clinicians and patients understand, where there might be some challenges in treatment, where they need to adjust, or maybe let's move towards a green medication where there's less likely to be some of these side effects. And I think one of the things that anecdotally we've really heard is clinicians have found having this tool as a shared decision-making tool to be incredibly helpful as they're going through these conversations. We know that, a large number of patients with depression will end up on multiple different medications during their treatment journey. And so this sort of gives a basis for, let's really talk about why we're going in the direction we're going, and can help really improve the trust that the patient has. So one question you might be having as well, this is a great tool. We're talking about minority health. How applicable is pharmacogenetics really to sort of the larger population? And so there was actually an interesting study that was published late last year, really looking at the real world actionability of this type of technology. And they did it in Alabama, and it was a population study. They weren't specifically looking at this type of technology only within the depression space, but this type of technology is available in the cardiovascular space, in the oncology space, and also mental health. And what they really wanted to look at was the actionability by race, and they looked at it among 4,000 residents of Alabama. And what they found was sort of across the board, regardless of race or ethnicity, having these actionable markers is really pretty prevalent. So not saying everyone needs to have this test, but this is an important technology that really can be utilized for any individual where you're really trying to make some of these challenging treatment decisions. Similarly, Myriad looked at a previous randomized controlled trial that we had done. And what we wanted to really see is, do we see different levels of gene drug interactions by race or ethnicity? And what you can see here, again, looking at red and yellow as compared to green, there really were no significant differences. So identifying individuals where there were these gene drug interactions, we saw that across the board for all races and ethnicities. So this really is a tool that can be utilized, for the wider patient population. So as we jump into how can Genesite be useful, one of the pieces that I wanted to chat through was just this concept of, what does current treatment look like in the area of depression? And really the current treatment paradigm, because there are so many different medications that can be considered, and none of them really are sort of the silver bullet to getting a patient to what we call remission, which is really the goal of treatment, which is remission essentially means that you now have, the patient no longer is depressed, and that's the goal of treatment. And the current paradigm is really trial and error. So you have, if we look at this graphic here, you have an influx of members that are suffering from symptoms of depression. Some of those patients may only need self-directed care. So some of those technology solutions like apps or ability to talk to families and friends may be all they need to get themselves sort of out of those symptoms of depression. But there's a significant number of individuals where they will actually present to their clinician, and in a conversation with the clinician, some may choose to really focus in on therapy, and that may be sufficient for them, again, to get to remission. But what data has really shown is that a majority of patients will at some point add in a medication to their treatment paradigm. And there was a landmark study that was published back in 2006, which really looked at what are the outcomes that we see for depression treatment. And what they found is that following that first line of medication, about 63% are going to fail that first line of treatment. And when I say fail, that means they don't achieve remission. So they might have some improvement in symptoms, but they still are depressed and they're still in the midst of depression. So they're not back to full functioning. And that's a really significant proportion of patients. Obviously, we've got, about 40% of patients who that first medication gets them to remission, and that's fantastic. What is concerning is as you continue on in that journey and make changes to the medication treatment, whether it's augmenting it or changing medications, with each treatment attempt, you see a higher proportion of patients fail to reach remission. So the more trials of medication that you do, the less likely it is that a patient is going to achieve remission. And that's a real challenge because often as you go on this journey, you have patients who obviously are still depressed, experiencing side effects, becoming less and less willing to be adherent to medications. And you get to a point where, you've got a patient who's really not doing well, and it's cascading to impact other aspects of their life and their health. And so that's really where, as we think about Genesite, where can this potentially be helpful? And I'm really excited to share some sort of late breaking data that we're going to talk about how does this technology really help improve clinical outcomes. And this is really building on a number of other publications that have come out showing that this can be a really helpful tool in getting patients to an appropriate clinical outcome. And so this study was just published last week. So first presentation where we're getting to share this data. I'm really excited to be able to do that today. This is data from a federally sponsored study that was conducted through the VA. And it was published in the Journal of the American Medical Association, so JAMA. And it was really designed, the VA was very interested in looking at the impact of pharmacogenetic testing on gene-drug interactions does that impact medication selection and then the ultimate goal of achieving remission in patients with major depressive disorder. And so just a little background on the study. This is the largest randomized controlled trial in mental health looking at pharmacogenetics as a tool to be utilized in the treatment paradigm. There were over 1,900 veterans at 24 locations across 20 states, so really trying to get a representative sample of patients in this study. And it was with a variety of clinician types. So it was clinicians in integrated health settings, in specialty mental health, but also in primary care. And one of the challenges is access to mental health professionals. So is this a tool that also could potentially be used in primary care settings where we know a lot of patients go to seek care? And there were two really key areas that the study was looking at that I mentioned sort of just based on the title, which is, does access to the Genesite result help in medication selection and getting patients away from sort of medications with significant gene drug interactions? And then sort of with that resulting, do we see improvements in clinical outcomes? And this study actually showed significant improvements in both of those. So it did show that when clinicians had access to the Genesite result, patients were much more likely to be on medications that did not have gene drug interactions. But then we also saw that there was a resulting significant improvement in remission with access to this. So we'd love to sort of help you figure out, where does this fit in within the context of treatment? So if we go back to the graphic that I shared before, we've got patients who've come in. In this study, they could have had therapy, and so they had failed on therapy to achieve remission, or they had taken an initial medication and had failed to reach remission on that medication. And so now the clinician was thinking about what was the next step of medication in this patient's journey. And what the data found was that for clinicians that had access to the Genesite information, so again, to that report sort of binning these medications, patients were 28% more likely to achieve remission compared to treatment as usual. And again, if we think back to the slide I had shared with you, where you got with each successive medication trial, you have fewer and fewer and fewer people actually achieving remission, a 28% greater likelihood to achieve remission in this population is really a significant improvement. These are now patients who no longer are depressed and are back to sort of fully functioning from that perspective. So really exciting data, and happy to answer more questions. It's sort of a quick overview, just given the time that we have today. But, again, what we know is that, there are a variety of tools that we're going to need to really help patients sort of achieve remission and get back to good health functioning. And Genesite is just one of the tools as a part of that toolbox. And as we think about the work that we're doing to really help break down barriers in care, in addition to just having a test, you need to have a sort of an infrastructure around that to really help ensure that patients can achieve the best outcomes. And so one of the barriers that we spoke to earlier was around access. So obviously there's access to mental health care, but then access to quality mental health care that's really going to help patients achieve the best clinical outcomes. And so when we think about Genesite, it is a clinician ordered test. So this is a test that a clinician would order and then a patient would do. One of the challenges, especially in a Medicaid population, is that patient going to make it into clinic? If they have to come back for a service, are they going to be able to? And so one of the things that we have developed is an at-home testing option. So if a clinician, say it's a telehealth visit, feels like Genesite is going to be a helpful tool, they can actually have a test kit delivered to the patient's house. It's a cheek swab that the patient can do and send back to the laboratory, fully sort of encompassed within the services we offer. And there's a 2-day turnaround time. So this information gets back to the clinician in a very timely fashion. So it can be used sort of in real time as the clinician and patient are thinking about next steps in treatment. The second component, which I spoke to a little bit just in the design of the study, is that the PRIME study sort of showed this, but there is additional data really demonstrating that Genesite can be used very effectively, both in a specialty mental health setting, but also in the primary care setting. And that's really important as we think about sort of integrating physical and behavioral health. A lot of primary care clinicians are really managing mental health conditions and depression treatment, and this tool can be very effective in the hands of primary care to get those patients to remission. Sort of the next is just around trust and how to help build trust, both between clinicians and whether it's health plans or Myriad as a provider, but also between clinician and patient. And so Myriad really invests a lot in ensuring that there is strong provider education. So when providers are utilizing a test like Genesite, they really understand the implications of those results and can use that effectively with their patients. And there's data to show, I had shared, that shared decision-making tool can be so helpful for clinicians, and data really has shown that when patients have access to that Genesite result and treatment is sort of planned accordingly, patients stayed on their new medications 46% longer. And obviously a big challenge in this area is medication adherence. So it can really help with adherence, and that 1 in 5 are actually on fewer medications. So helping to reduce the polypharmacy that we see. And then lastly, sort of not related to the technology of the test per se, but really as we think about Myriad's work to help break down barriers, part of it is really understanding what some of those barriers are and hearing from people in the community around what they're doing to really help address some of these. And so a couple of areas that I just wanted to highlight is the Genesite Mental Health Monitor. And this is a nationwide survey of US adults that really has been conducted to assess barriers to care. And the most recent one was really looking at women and depression. And it was interesting in that they found that 6 in 10 women surveyed with depression or anxiety diagnoses feel like they've been ignored or dismissed by their families and friends when they've tried to discuss mental health concerns, and they often delay going to treatment by over a year. So that's really, a key challenge. And so that type of information could be really helpful as a community for us to think, how can we break down some of those perceptions? And the other is really the Genesite Care webinar series, which is a series that's really devoted to identifying these barriers and then bringing voices of experts to talk about some actionable solutions. So a couple of the more recent webinars have been The Talk: Parenting Through Racism and Its Impact on Mental Health, and Coming Out as Hate Awaits: The Impact on LGBTQ+ mental health. So really a variety of ways in which Myriad is trying to be one part of, obviously a much bigger solution that we need to have. But I know I have been talking for quite some time, and so this is sort of the conclusion of the slides and the data that we have presented. But I am looking forward to hopefully helping answer questions. And so I'm going to transition it over to my trusted colleague, John Edwards, to facilitate the Q&A. And I think I'll just end by saying, we know that we're just one part of this, and the tools that we have are just one tool to help in sort of a bigger area of driving health equity, but also especially in the context of mental health. And so look forward to hopefully, whether today or in the future, being able to have conversations to see how we can partner together. So I'd love to invite Gwen back, and then John, if you want to lead us through the Q&A, that would be wonderful.
You bet. Thank you, Devki and Gwen. We are getting some questions and comments in the Q&A feature. We have a question and a comment that I think are pretty related. So, does Genesite tell you which medications will work? And this comment, metabolism doesn't speak to efficacy, though.
Sorry, take myself off mute. Yes. So yes, I think it's a great question. So what the metabolism and what Genesite is able to do is to really look to where do we anticipate significant gene drug interactions occurring, where patients are less likely to respond. And there is data, there was a previously published randomized controlled trial that looked at when you take a patient off of one of these medications with a significant gene drug interaction and move them over to one without, there was a 153% increase in the ability to achieve remission. So definitely the goal of the Genesite test isn't to say this is the right medication, it's to provide the clinician where are there potential interactions that could be problematic. So as they're looking at future therapies, they can sort of take that into context to think about what that next treatment is going to look like.
Okay, the next question, does anyone actually cover this test yet?
So that is a great question. Yes, so this is not a new test. It has definitely been around. So Medicare has covered Genesite for quite some time. Following, I think it was 2016 when they started covering the testing. And they actually expanded coverage following the publication of data that really looked at the fact that Genesite in the hands of a primary care clinician can be just as effective as those when it's used by psychiatrists. And so originally in their coverage, it was psychiatry only, but they actually opened it up to all provider types sort of based upon that data. So there is definitely coverage there. United Healthcare also does have coverage for their commercial, but also medical policies for their managed Medicaid lines of business as well. And I think when we think about Medicaid, my team, I'm very lucky to work with a team of really talented individuals, and our focus really is working with Medicaid health plans, but also state agencies. And so a lot of the data that we have talked about has been published over the past couple of years, and with the pandemic, we had been mindful about coming forward to have these conversations, just given everything that was on your plate. So we're really looking forward to talking. But yes, we're starting to see more coverage for Genesite and are really excited to be able to have these conversations.
Next question, what percentage of those tested have red results?
So that's a great question. In terms of within, I'd have to go back and look at the studies to say, John, I don't know if you know off the top of your head.
Hesitant to cite the number off the top of my head, but I know we roughly halved that percentage in the Genesite arm versus that treatment as usual arm.
Yeah, I think it was, we halved it, and I'm worried if I pull the study up to look at it right now. We will promise to get back to you with that, but there was a significant portion of individuals who do have red results. I feel like it was in the 15 to 20% range, but we'll get back to you with that information.
Okay, next question. What types of clinicians can order or use Genesite?
Yeah, so it really falls within the scope of practice for the clinician. When we think about, Medicaid coverage of it, it's really clinicians where this is within their scope of practice. So we see ordering from psychiatry, nurse practitioners focused in psychiatry, physician's assistants, primary care providers, OBGYN. So we see a wide variety of clinicians utilize the test when they are treating patients with mental health conditions.
All right, the next question. Thanks for sharing the data from the PRIME trial. Were these all veterans? How would the results from this study translate to a Medicaid population?
Yeah, I think it's a great question. And definitely the study was focused in the veteran population. So these were individuals who were veterans. I think one of the interesting pieces is obviously we know that there are a large number of veterans who actually have Medicaid as their primary insurance. I think it's around 800,000 veterans have Medicaid as a payer. So definitely relevant from that perspective. I think the other pieces in this population, as we all know, veterans in this study, they had higher rates of PTSD as well as treatment-resistant depression. And we know that many individuals with Medicaid have coexisting mental health conditions, and so they can be even more difficult to treat. So I think what this data really shows is that even in those difficult to treat patients where they have depression along with other, whether it's PTSD or in a difficult to treat population, we did see significant improvements in remission and really getting them sort of out of that depression diagnosis.
Okay, the final question to address in the Q&A, so please enter questions if you would like to. And this question is, what would a partnership centered around Genesite look like?
I think we're open to anything, honestly. But really, I think, we definitely have been in discussions with different health plans around what a partnership may look like. And I think part of it stems from what are some of the goals that your organization has and what you're trying to achieve, and then trying to come to a way that we can partner, whether that's a value-based agreement, a risk share agreement, or just really finding ways to partner to help the efficacy of Genesite be as much as it can be. And so I know some plans are really focused on medication adherence and what can they do in that area, so we can design things around that. Others are looking at, emergency room utilization or inpatient hospitalizations and reducing some of those. And so we have data sort of that has shown improvements in those areas. So really it's open for discussion, and we're really looking forward to talking with you about what that might look like for your organization.
Okay, so John, was that the last question? I think you said it was.
That was.
Okay, perfect. Well, with that, I want to thank Gwen and Devki very much for your time today, your expertise. This is a hugely important topic to MHPA and our members. In fact, our annual conference that's coming up in September, this is exactly what our theme is all about, which is Medicaid managed care, driving equity, delivering value, improving lives. So thank you so much for your time today.
Thank you.
Thank you very much, Patrick, and thank you all for attending, and definitely feel free to reach out with any questions following this. We will be sending an email with the slides and the link, and so you will have an easy way to get in touch with us if you have any questions or if we can set up some time to chat further.
Yes, indeed.
Perfect. Thank you, guys. And thank you all for attending today. And look for another webinar from HPA, same time, same place. And we'll be talking about bids. So hope to see you there. And don't forget our annual conference, September 14 to 16 in Phoenix. Hope to see you there. All right. Thank you all. Bye-bye.
Thank you, everyone.
Thanks.